So as we know that exon 20 is the third commonest EGFR mutation which has been seen. So averages around 3% of the population would have this kind of mutation. And we know that with the current first generation, second as well as third generation TKIs, the responses are quite dismal. Platinum based chemotherapy cocktail remains the standard of care. But what is beyond that is something which is not known. And if you know that the median survival of patients with EGFR mutations other than exon 20 could hover around 40 months, whereas the patients with EGFR exon 20 insertion has median survival of only 16 months. So there are probably a lot needs to be done in this space. And we have two drugs. One is the monoclonal antibody and one is the TKI Mobocertinib. This particular paper went on to study indirect comparison of Mobocertinib versus real world data outcome in a refractory non-small cell lung carcinoma with EGFR exon 20 insertion, which was presented in annual meeting of 2020. As we all know, I think this is something which I had alluded to initially. EGFR 20 insertion disease involves rare mutations, almost 6% of all EGFR mutations, and currently no approved therapy has got interesting or impressive response rates. In an ongoing single-arm phase 1, phase 2 study, in preliminary analysis at least, Mobocertinib has shown evidence of anti-tumor activity in previously treated patients with non-small cell lung carcinoma and EGFR exon 20 insertions. So the objective of this particular analysis was to have overall response rates and a progression-free survival. This was an indirect comparison again. So we will have to take these results with that prism. But nonetheless, with the lack of data in this particular setting, I think this study is important. So the methods were again the patients with EGFR exon 20 insertions treated with 160 milligram per day in an ongoing single-arm phase 1, phase 2 studies were included, and they had a standard inclusion criteria. And the patients with the real-world data, RWD arm, also were similar, who had refractory non-small cell lung carcinoma, had first line of platinum-based doublet, and then were treated with various cytotoxic regimen in a real-world setting, and including some of the TKIs as well as immunotherapy. Patients who received prior chemotherapy were included in the statistical analysis. So these were the demographic and baseline patient characteristics, almost matched in both groups, both in terms of race, ethnicity, smoking status, performance status, presence of brain metastasis, number of prior regimens, especially that's very critical, and prior chemotherapy exposure. Almost large number of patients did have prior chemo exposure. Second line treatment results pattern for patients in real world data analysis. Types of therapy which the patient received were IO, EGFR, TKIs, chemotherapy plus monoclonal antibody, chemotherapy plus EGFR TKI, chemotherapy plus IO, EGFR TKI and monoclonal antibodies, and others. So in real world data, that there was no consistent regimen for second line treatment. Large number of patients did receive immuno-oncology drug because that sometimes becomes the only choice that we have. A lot of patients received second line docetaxel, which is again the standard of care, and some of the patients did receive TKIs. In the primary analysis, which was the overall response rates, was one of the important primary endpoint. Patients treated with Mobocertinib, 160 milligram per day, had got a response rate was 43% vis-a-vis 14%, which is then treated with the second line treatment in the real world setting. So in terms of the response rates, at least the results are quite impressive, almost 43% versus 14%. So that's a very, very impressive percentage. And the second analysis was the progression-free survival comparison. And if you could see here, there is a dramatic difference between the patients who received Mobocertinib versus real-world data, unweighted and weighted both. Significant, the curves are separating all throughout right from the start, and they continue to separate. So the PFS benefit also was continued to be received by patients who received Mobocertinib versus real-world data. Patients from Mobocertinib trial were compared with RWD patients who received chemotherapy in prior lines. That was a sensitivity analysis, and it was found that Mobocertinib showed better efficacy than a real-world treatment options that was chosen in exon 20 insertion patients in this group of patients. So the authors concluded that among pre-treated patients with non-small cell lung carcinoma who had exon 20 insertions in this phase 1 and phase 2 study, Mobocertinib demonstrated significantly longer PFS and higher overall response rate compared with other second line treatment option used in the real world setting, even with baseline propensity matching. despite the difference between the real world data and the trial data, real world data can be used to provide a comparative evidence for a single arm trial in the absence of direct head to head trial, which is currently not there. And a trial comparing mobocertinib with platinum based doublet as a first line therapy. An exon 20 insertion is currently recruiting patients, and probably we should get the results of this trial soon. 40 milligram 4 tablets, honestly, I have not used this drug. It is to be supposed to have been imported from Europe. And side effect profile, which is mentioned, is interstitial lung disease, fatigue, and diarrhea. So, if anybody in the audience has got some experience, I'm not sure, but the data definitely looks impressive. Mobocertinib, this is a patient of abivantinib. Okay, so I do not have personal experience, but I don't know.
My question was to that if you have an exon 20 insertion, you have the option of amivantinib and mobocertinib. What would be your choice?
I would prefer the oral one. It's quality of life, and I think amivantinib has got a lot of infusion-related reactions as well. So I would prefer the oral one. Though again, a huge disclaimer that I don't have an exposure to either of them, but this looks attractive.
Shruti, you have used amivantinib a lot. What would be your
Shruti
choice?
had used, yeah.
So more than the infusion related reaction, because when you split the dose, you don't see that I've not seen. So we always give the first dose in ICU, split dosing, everything in ICU, yes. But I have not seen a. So we have the okay. So resource.
So Dara,
But
you
more
have
than that, the side effects of paronychia and the skin and scalp lesions, to an extreme degree, that is more problematic. So I also don't have any experience with mobocertinib.
yeah. But what is the percentage of infusion reactions with?
So with amivantinib, with the revised schedule, which is split dose, and first time you go with 50 ml per hour and then to 80 ml per hour, we also have not seen. We have given it now to 20 plus, which we have also not seen in Tata.
Yeah, because DARA is quite toxic. DARA is 37 to 80%, 40% incident, irrespective of whatever you do. So that's a very nasty drug to start initially.
But I agree, the paranoia is really bad.
Okay. But I think something we have for this exon 20, which is good. Either of these two options looks interesting. Yeah. So here they are mentioned as ILD and diarrhea and fatigue as the most important treatment-related side effects.
Madam, we have a trial going on for exon 20. So we enroll in the trial. The amivantinib which I'm talking about, all has been given in the trial.
It's ongoing.
Exon 20 insertion trial is ongoing.
First line.
First line, yeah. I think Shruti also has that.
But how do you, I mean, in CGP, do you pick up, there is one exon 20 insertion mutation which is responsive to TKIs.
I remember
7A76.
Y764, yeah.
So that has got good response rate with osimertinib.
It also responds to geftinib.
Any geftinib, yeah. So in CGP, does that is that variant picked up?
So what we do is, I'll tell you, we have some fixed panels PCR
Okay.
for few types of. We don't cover all type of exon 20 insertion. We cover the common types. So we will be covering 50 or 60% of what the total types of exon 20 insertions we have. So
Okay.
that
will pick it up.
That will pick it up. We must be missing at least 30-40%. What's also seen in literature that if you do an NGS via as a PCR, you would miss at least 50% of exon 20 you will miss.
So I had used osimertinib double dose. There is some data to support that, but experience was not very exciting. It just progressed.
What about TK and VEGF? I mean, the old days.
Madam, so I'll tell you that we had published our experience of exon 20 of around 22 patients. Before that, Shruti had also analyzed. Our experience was very bad with exon 20. Our median survival was 5 months. So every patient which came to in that series, our rate of percentage, it was around 8%. And most of the patient had a poor performance status and came with quite severe burden, and none of them actually responded to chemotherapy.
But still platinum-based doublet continued to remain standard of care till now.
So
So,
if you don't have this platinum based,
so this trial is the first line trial you're talking about?
it's first line.
First line.
platinum.
Thank you.
Thank